Thank you for invitation to this interesting meeting. So my viewpoint is that health workforce shortage is a failure of the system, a disease of the health system. And the question I would like to discuss with you is what are our diagnostic tools to diagnose this shortage, and how should we go forward to get better and not contradicting figures about health workforce shortage. Now, it's absolutely necessary to integrate health accounts or labor accounts in the system of health accounts. Now, I think that the graph presented by Dr. François Decaillé, 2007, in a meeting of the Regional Europe World Health Organization, makes very clear that the connection between health and economy is over labor and education and productivity. Also now the Sustainable Development Goals are clear in that direction, that they say health labor is a precondition for health coverage. Now there are so many points which claim for further analysis of health workforce shortage, and the question arises, why, as we know that already a long time and discussed that already now 20 years, why are labor accounts not yet integrated into the broader system of health accounts? Even there are limits in the national accounts. One point is certainly that outcome measurement was a priority, and complexity, missing statistical resources, workload in the European system of health system of statistical accounts are other factors which contributed to these limits. But however, there are experimental statistics which are very promising. Now, the good point is, the good news, it's really that there are possibilities to link the different accounts. And by this is it possible to say something about the total workforce in working in the health system. One could say, oh, that's a simple question, why we do not use that and why we do not discuss that. Now, the point is that we have very different systems and do not combine it. Now, the linkage is possible, as I say here, over the common activities in industries. And we have done this, and I will show you some results. Now, let's start with the national accounts and the workforce in the national accounts. There you can see on the right side Germany with the highest figure of employment in healthcare in European 27. Germany has the highest number of persons working in healthcare, 38.6 per thousand population. And Germany and Denmark employ almost twice as much people in healthcare as Romania, Cyprus, Croatia, Bulgaria, Greece, and Hungary. Most states, as already was mentioned by Jean-Christophe, of Central European countries are at the lower side. Now, in social care, the disparities of workforce densities are even higher. But the main problem is that we consider this in Germany. We have still in Germany a workforce shortage. Now, if we combine the system of health accounts, that means financing data, with employment data of national accounts, then we get this picture. You can see the Nordic country in Germany with high expenditures and high employment. And in Portugal, you find high expenditure, and in Spain, high expenditures but low employment. And this is what we have to consider. And but SHA, the system of health account, and the system of national accounts, in combining to each other, helps us better to understand what is behind this structure. Health labor shortages are measured regularly by the public employment services and reported. These are the data from 2016. And you can see in this study from the labor offices who reported shortages, you find a lot of countries which are on the top of countries with high employment ratios. So we see that shortage of occupations are often combined with high employment. Detailed statistics allow furthermore vertical and horizontal mismatches to analyze across skills. Now, this means that you maybe have too many people in higher educated jobs than in lower educated jobs, or in assistant professions than in higher educated professions. Now, a complete contradicting build is given by the global burden of disease approach, which measures needs-based health workforce shortage across not only the European 27 countries, but around the world, with about 195 countries or 91 countries. But in this approach, health workforce shortage does not show any shortage for many European countries. This depends also on the approach chosen, namely only minimum health workforce is accounted. So the present global burden of disease approach, and also the approach used by WHO, does not distinguish different types of skills and mismatches, and is linked to the global development of income, and does not very help much to analyze the shortages within European countries. Now, what could be a remedy? Like the global burden of disease approach, there are health or disease-based accounting tools available, and it's possible to see the growing interdependency among health labor in integrating accounting systems with deployment services, healthcare and outcomes measurement. The HADIC project of Eurostat has shown the feasibility of cost of illness accounts in Europe. Technically speaking, this means linking health labor accounts and health disease accounts requires to link diseases and conditions, professional skills and labor coefficients into SHA. Detailed data on working time and professional inputs across diseases are required. Big data are needed or may be considered to get more light in the variation of comorbidities and flows of skills. And these basic tools we need to understand better why we are reporting with one instrument shortages, and in the other instrument we have a complete contradicting view. Now, it's not only that we have to work, I think, more in linking accounting tools, but go back and discuss what are really the basic assumptions behind our models, and when we measure shortage, and how we can define nationally standards of health workforce shortage, because we have very different standards, for example, for primary care doctors in European countries. Now, the SHA core framework and the location of cost of illness accounts or and health labor accounts can help us to get here more shade, more light into the flows of health workforce and into the stocks. How to organize integrated health labor accounts across member states in practice, it's also an important question, what we have to address. I think the WHO handbook on health labor accounts includes very helpful steps to go forward and to help us to develop a better diagnostic tool to discuss this issue and to understand the problems in Europe. I would like to end with this, because we are still in the beginning of understanding what is really behind that, and need to go forward with this practical, empirical research and accounting. Thank you very much for your attention.